Hello, everyone, and thanks for joining Streamlining Your Surgical Workflows for Better Financial Outcomes webinar. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being fully recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode. If you have any questions, please type them into the questions section on your GoToWebinar console. At the end of the presentation, we'll have the Q&A session as well, and we'll get to as many questions as we can, but if for any reasons yours is not addressed, someone will be able to follow up with you after the presentation. We like to keep things interactive for those attending. Throughout the presentation, we'll be launching poll questions for you to answer. Today, we have two presenters from IMO, David Bocanegra, Nurse Informaticist, and Alex Dawson, Product Manager. As mentioned before, if you have any questions or comments while our presenters are speaking, please type them into the questions section on your GoToWebinar control panel. With all of this being said, I would like to pass it over to David Bocanegra.
David Bocanegra, and I'll be doing this presentation along with Alex Dawson, and we're going to talk about the operating room and surgical scheduling and reimbursement. Statistics show that over 48 million surgical inpatient procedures are done in the United States annually. As the need for perioperative services grows, there's also an increased need to optimize these workflows and the time that's spent in the OR when performing surgery. In this presentation, we'll discuss some critical pieces that need to fall in place in order to streamline these surgical workflows and increase overall profitability. Surgical services occur in two areas. They can occur in hospitals and also in ambulatory service surgery centers, also known as ASCs. Within the hospital, these procedures can be done either as outpatient or inpatient. In the outpatient context, patients are admitted to the hospital and leave the hospital on the same day of surgery. In such cases, the patient will recover at home. For inpatient surgery, patients usually arrive on the day of surgery and stay in the hospital as long as necessary to recover. Many outpatient surgeries are performed at ASCs, which are distinct from hospitals, though often associated with a hospital. Unlike hospitals, though, ASCs are not equipped for emergencies or overnight stays and typically are only open 8 to 10 hours on weekdays only. Effective management of an operating room suite in either environment requires planning. First, you must know how many cases are scheduled on a particular day to ensure that you have the capacity, personnel, and resources. The second consideration is the management of that daily schedule with regards to the order in which operations are booked. This is determined by a few factors to include patient condition, type of procedure, procedure time averages, and the availability of specific rooms, equipment, etc. Surgical scheduling is very important to this process as a fully staffed operating room is very costly to run. Some studies estimate that expenses can exceed $1,000 an hour. Though expensive to run, however, operating rooms typically generate most of the total revenue for a hospital. Incorrectly scheduled surgeries, however, can result in increased costs due to improper room setup, wasting of supplies, and complete loss of revenue in circumstances where the patient is in the incorrect admission type. Many of these factors can be reduced or avoided completely by having a healthy surgical scheduling dictionary. Surgical scheduling dictionary health is vital, and a healthy surgical scheduling dictionary must contain a few of these key elements. Effective management and maintenance of the surgical scheduling dictionary are vital to scheduling efficiency. Due to the ever-changing and evolving nature of the perioperative space and surgical techniques in general, without an effective management strategy, these dictionaries can become outdated very quickly. Dictionary maintenance must start with good governance. There must be a process in place that ensures that newly added procedures are not duplicative, are unambiguous, and most importantly, make sense clinically. Poor governance can lead to the creation of multiple duplicative terms, a lack of or loose naming convention, which among other things can cause ambiguity and confusion as to what is the intended procedure. The above examples can also lead to a very challenging search experience when booking cases. Some indication of poor dictionary health are listed here: difficult procedure search, poorly maintained CPT codes, a close enough approach to scheduling, preference card management issues, as well as poor procedure time averaging. When scheduling, the inability to quickly find the correct procedure name, lack of or inconsistent CPT codes is very frustrating, and it can lead to a close enough approach whereby the person booking the case will pick a procedure that is not exact, but close enough to communicate the general idea of what surgery will be performed. There's many problems with this approach, however, perhaps the most severe being that the case that is being scheduled is not the case that will be performed. It should be quite apparent that this can create a potentially dangerous situation and would require a process that contains comprehensive checks and balances to prevent a patient from having the wrong surgery. It should go without saying that an incorrect or wrong site operation, aside from most importantly being damaging to the patient, is costly not only financially but also to the reputation of the institution. Preference card management, that can be a tedious task in cases where dictionary health is not an issue, but imagine a procedure dictionary that lists procedures that aren't used anymore, or perhaps includes many duplicative or ambiguous terms. Those examples make CPT code mapping and efficient management of preference cards nearly impossible. Accurate time averaging will also suffer by having duplicates or ambiguous procedures due to the lack of consistency in how these cases are scheduled. So hospital processes and surgical scheduling. Efficient surgical scheduling can be challenging with everything it is demanded of it, such as special requests from surgeons, differing staffing requirements from case to case, and the potential for adding cases to an already full day. Some fundamental principles should be followed to make the management of the surgery schedule much more straightforward. At a minimum, the entire patient care team must have the same understanding of the intended procedure to ensure things like correct room setup, correct supplies, equipment, and personnel. I included this quote from Dr. Satardi, and I hope I'm pronouncing his last name correctly, but as far as his practice concerned, he says that in many ways, surgery schedulers are the unsung heroes in a surgical practice. Our schedulers make the complex coordination of schedules look easy. They're strong team players and provide great service to our patients and physicians. So to that end, when we talk about surgical scheduling, I believe this happens in two parts. You have the process of the request and then the traits of the scheduler. So all hospitals have a process in place to schedule surgery. The request for operations, whether on paper or electronic, at a minimum should ideally include the patient's pertinent medical information, including allergies, diagnosis, reasons for the surgery, admission status, a clinical description of the intended procedure with the expected CPT codes for pre-authorization, and any special requests. It should also include guidance for specific scheduling situations, such as add-on cases, as well as changing or canceling already scheduled operations, as in these situations, things will have a real-time effect on operating room utilization. As far as the scheduler is concerned, schedulers first and foremost should have excellent communication skills as they are continuously engaging with physicians, patients, and ancillary staff. It is also essential that the scheduler is familiar with all aspects of the surgical scheduling process and operating room routine in general, because an in-depth understanding will enable them to be flexible when contingencies arise, such as a change to a case that will significantly affect the duration of the surgery, add-on cases, or cancellations. All of these situations must be managed with minimal impact on the operating room utilization. Coordinating these and other variables can be frustrating, so it's essential that the scheduler be able to maintain a positive attitude and assume a proactive approach when changes occur to problem solve and make the appropriate accommodations effectively. As far as scheduling decisions go, when scheduling surgery, it is of utmost importance to reinforce the principles of patient safety and good quality care. Decisions cannot be made about the patient if you don't know the patient. This is especially important when considering add-on cases. At times when scheduling add-on cases, another patient will have to be bumped to another time slot, or perhaps even need to be rescheduled for another day. The operating room staff must be aware of the various patients' medical conditions so that the quality of care is not compromised. Most operations require that a person have nothing by mouth after midnight on the day of surgery. A patient with diabetes should not be restricted from eating or drinking for long periods. In this example, this patient ideally should be the first case, or at the very least, they should be scheduled for the morning instead of later in the day. Proper use of resources requires that you schedule as many cases as possible while also considering patient safety, the availability of supplies, equipment, and essential personnel. It's necessary to track under as well as overutilization to ensure that appropriate supplies and equipment are available and to ensure that staff is neither idle nor overworked. Accurate case time averaging and analysis of historical utilization data will provide the insight needed to target the number of daily operating room hours required for an average surgery day and to allow for informed decisions for scheduling to improve efficiency. Surgical scheduling and pre-authorization. So pre-authorization of cases with the patient's insurance carrier is essential to receiving proper payment for surgeries. Most surgeries require insurance authorizations. In some cases, these schedules work on short notice, particularly when trying to add an urgent surgery to an already full OR schedule. When booking an operation, the scheduler must know the exact intended procedure to be able to obtain insurance pre-authorization efficiently. It is vital at this point in the workflow that the scheduler has the correct CPT codes, as this will ensure the best chance of proper reimbursement. Incorrectly pre-authorized surgical cases can result in little to no reimbursement, especially if the case is one of the many operations which the Centers for Medicare and Medicaid Services, or CMS, deems as inpatient only. CMS has determined that specific surgical procedures require that the patient have at least a full day of monitoring and recovery time as an inpatient. If any of these CMS inpatient-only procedures are scheduled incorrectly as outpatient surgery, in many cases, the hospital will receive no reimbursement at all. And this rule not only applies to the costs related to the operation itself, but it can also extend to all charges for the entire hospital stay, including any other hospital services that the patient received, such as an emergency department visit before admission, those associated x-rays, labs, etc. So it's important to always be evaluating for a need for change in your process. In general, all processes should be evaluated as part of any quality improvement plan. The same holds true with surgical scheduling. Are changes necessary to improve safety? Is the process clearly defined through all workflow steps? Is the process efficient? Does the process include checks to ensure proper reimbursement? These are some of the questions that should be addressed when examining the surgical scheduling workflow. When thinking about continuous quality improvement, it is essential to evaluate all workflow processes at regular intervals to ensure that there are no reasons to change, or more to the point, to find reasons where change is necessary. This does not mean, however, making changes for change's sake. Concerning operating room scheduling, it is vital to ensure that whatever method is in place accounts for patient and workplace safety, and also a practical assessment of any process should start with the question, do we need to change? Other matters to consider are, is the workflow clear with guidance for contingencies, and what contingencies need to be addressed? How does the scheduling process affect reimbursement? Does the scheduler have the correct CPT codes for pre-authorization? What checks are in place when CPT codes are incorrect or unavailable? How does the denial process work, and who owns the responsibility for follow-up? And does the patient have the correct admission class for the intended procedure? Surgery scheduling processes can differ significantly from one institution to another. The answer to these questions make an excellent starting point to determine the need for change. Review of case time averages and OR utilization in general should be done regularly, as well as inconsistent case time averaging can lead to under or overutilization issues, which will definitely impact surgical scheduling. Some key takeaways from the content so far: dictionary health and regular maintenance, communication, hire and train well, create and use those processes, eliminate redundancy, and anticipate patient needs. A healthy surgical dictionary should contain only appropriate active procedure terms. mapped to up-to-date industry standard code sets. Causes of an unhealthy dictionary are multifactorial and require a defined program to achieve and properly maintain good dictionary health. And this can only be achieved with regular review, executive support, and good governance. Effective communication is vital to all aspects of medical care. All involved in the patient's care must have the same understanding of the patient's condition and needs. If this is not the case, this in itself is evidence of a breakdown of communication somewhere in the chain. Techniques to enhance communication do not have to be multi-stepped or complicated. Something simple, such as a quick staff huddle at the start of the day or before every surgery, is a great way to ensure that all are on the same page. When instituting any process, you must have, as a starting point, the appropriate personnel. It is essential for success to start with the right staff and a formal training program so that all employees have the same understanding of all workflow steps. It is also important to include training for all levels of experience. An employee may have many years of experience, however, it doesn't mean that they know how the process works at your facility. Create and use processes. Processes, even very involved ones, save time. If they don't, well, then this in itself would be a reason to re-examine what you're doing. The surgery scheduling process should be centered around patient flow. Improving patient flow would be the most significant change to affect efficiency and productivity. Ensure that any overlap of tasks and responsibilities is minimal and only present to ensure safety for the patients. For example, there may be many points in the surgery scheduling process to assess and verify the patient's medical history, allergies, daily medications, and understanding of the intended procedure. And then it's very important to anticipate patients' needs as part of this process. So creation of handouts of what to expect prior, during, and after surgery, an information sheet about the planned surgery will ensure that the patient understands the operation as well as provide insight into those operative phases. And then allow the patient to receive and process this information and provide time to answer any questions they may have. At this point, we're going to ask our first poll question, and when we resume, Alex Dawson will be the speaker.
Thanks, David. All right, at this time, please refer to your screen for your first poll question. How efficient do you consider your surgical workflows? Very efficient, somewhat efficient, not efficient, or not sure? Give it a few more seconds, and then we'll close out for today. All right, thanks all. Now, at this time, we'll pass it over to Alex Dawson.
Thanks, Jordan. Yeah, like Jordan said, my name is Alex Dawson. I'm a product manager at IMO. So now that David has talked through, a lot of content focusing in on surgical scheduling, now what? What are we supposed to do now that we are more aware of what some of the issues might be? So surgical procedures manage to account for 40 to 70% of hospital revenues. Maximizing this potential in your operating room for revenue margins is not going to happen because of a single change that you make. Rather, there are foundational elements that must be in place and practices that must be established to set up your organization for improvement, both in the near and long term. Zooming in on scheduling helps us see the many potential issues and dependencies within this one area and the implications to the organization. But what should you do now, and where should you focus, and what strategies should be considered to set you up for scheduling improvements? So when we think about workflow and we think about how to optimize it, when we think about how to improve scheduling efficiency and overall financial performance, it's important to look at the entire workflow and understand how the various pieces interconnect. When you understand the scheduling workflow, the quality of your data, where data is input, who reviews that data, and the financial outcomes of the entire process, you will put yourself in a much better position to improve the overall performance of your operating rooms. To ensure you have this understanding, a healthcare organization must first set out clear and measurable improvement targets. If basing your targets on financial outcomes, your metric could be decreasing denials due to improperly scheduled procedures. If basing this on improving operating room efficiencies, some key efficiency metrics include accuracy and case duration estimates, the percentage of on-time first case starts, the percentage of cases that had a pre-anesthetic checkup prior to surgery, patient in to incision time, measuring the average time that elapsed between the patient entering the operating room and the first incision, average turnover time, measuring the time that elapses between the prior patient exiting the room and the next patient entering the OR. To guide you in achieving your goals, evaluate your current scheduling process for understanding and to give you context in your decision making. One tactic is interviewing those involved in the process themselves, from schedulers to surgeons to nurses to coders, leading to insights into their struggles that might not be apparent with a workflow diagram. As you examine this process, you might find that there are insufficient checks and balances in place to ensure strong data throughout. You also might find that issues can arise because of unclear ownership of certain scheduling activities or a lack of clarity and communication between personnel or during the workflow. So let's talk about how to improve some of these common foundational elements that David brought up. Let's talk about the dictionary. So scheduling effectively requires an understanding between your ordering physician and those tasked with preparing for the surgery. This communication translation is often difficult. Schedulers not being sure exactly what the intent of the surgeon is can lead to selecting a suboptimal procedure, leading to delays, waste, and even insurance denials. This communication problem sometimes stems from inadequate governance of your dictionary of surgical procedures. Over time, this dictionary can be full of similarly named procedures added from different service line leads that needed something scheduled urgently and found that the existing procedures did not cover the intent of the surgeon or that their service was not authorized to perform the procedure. These duplicative procedures can lead to confusion when scheduling, excessive or duplicative preference cards, and a high maintenance burden of the data. Having a dictionary policy in place to review what gets added or changed can pay dividends in helping streamline communication. Regular maintenance of your dictionaries is also important. Even a strong governance policy will miss things on occasion and cause issues. By regularly ensuring that your list of procedures accurately reflects those that your organization performs and that your CPT mappings are accurate, you can reduce the overhead of regular preference card reviews or updates and build a solid data foundation. Really, your surgical scheduling dictionary is where the intent of the surgeon is recorded. Its health is vital to scheduling and adjacent workflows. So, and now we're going to move into a second poll question.
Thanks, Alex. This will be our second poll question. How accurate do you think your organization's surgical dictionary is? Very accurate, somewhat accurate, needs improvement, or not sure? Okay, a few more seconds. Awesome, thanks so much.
Hey, yeah, thanks everybody. Let's talk about pre-authorization. So we discussed the potential for improved financial outcomes earlier, and a key place that denials can be reduced is when pre-authorizing a procedure before it is performed. On the last slide, we talked about the importance of your surgical dictionary, but another key element of a healthy dictionary is CPT code mappings. When taking a surgeon's order and setting the schedule, it is crucial that the proper CPT code be used when pre-authorizing. While a CPT might come from the surgeon, it is helpful to have a current CPT code or codes mapped to the procedure being scheduled to facilitate the pre-auth. Accurate CPT mappings coupled with built-in EMR alerts can also bring attention to situations like the presence of a Medicare inpatient-only CPT code. For schedulers or pre-authorization personnel, knowledge of the need for an inpatient setting can mean the difference between a full reimbursement for a procedure and an outright denial. These types of denials can be costing your organization hundreds of thousands of dollars or more. proper dictionary health and data-driven alerting can lead to better financial outcomes. So a different type of impact is with your preference cards. Those present a unique challenge to a healthcare organization. It has been established through several studies, including, and I like David, I'm not sure if I'm pronouncing his name right, but Zygarakis et al., who estimated that for a single neurosurgical department, there is approximately $968 of OR supply waste per case, which that comes out to $242,968 per month and $2.9 million per year just in supply waste. Clearly, there are significant savings to be had in optimizing the use of surgical supplies to minimize this waste. The revenue and environmental implications are staggering. Zygarakis said, Al go on to recommend price transparency of supplies to the staff, education about OR waste to surgeons and nurses, regular preference card reviews, clarification of supplies that should be opened versus available as needed to reduce waste. Preference card reviews are time consuming and can suffer from a lack of clarity about which cards need the most attention. In addition, duplicative cards can increase the burden and confusion during the review process. In order to help ease this burden and promote success in your preference card optimization efforts, it is imperative that you identify the procedures that are actually performed in your organization and create a healthy surgical scheduling dictionary. Doing this prior to a large-scale preference card review can lead to better focus, a shorter list of cards, and a better sense of priority for the review. So to recap, setting goals, measuring progress are really your first steps. If you're not sure exactly what you're trying to improve, there's a higher than usual chance that your project might not be as successful as you want it to be. The surgical scheduling dictionary is the data foundation. It's really difficult to make improvements in certain areas if you don't have that cleaned up. It's a key determinant of decreasing denials, making sure those pre-auths go through, better efficiency, and making sure that your preference card management work is focused in the right areas, and it can really help you save money in the supply waste. Okay, and now on to our third poll question.
Perfect. Thanks, Alex. Okay, what is your biggest pain point during your pre-surgical process? Preference cards, scheduling, surgical dictionary governance, surgical pre-authorization, or all of the above? A few more seconds. Awesome. Thank you.
All right, so thanks everybody for responding. So just to conclude here, two key points we want to hammer home. So surgical scheduling is a key element of overall OR efficiency. And I think we've established, just talking about it, how it is really that key point in the workflow and can really have implications beyond just that one step. And that has large revenue implications. And then your scheduling dictionary is a key element of a high functioning surgical scheduling process. Okay, and now we're gonna open it up to some questions. So go ahead and use the built-in question submitter, enter in your questions, and we'll go ahead and see how many we can answer.
Please excuse any brief silence that we have during this while our team looks at them and reviews to answer.
All right, we have a
Okay.
question. This is David. We have a question. Whom for my organization should be in charge of data governance? I think that starts, I mean, that I think it's everybody's responsibility really, but I mean, it starts with processes, of creating that process and assign that. I mean, you as far as data governance for the surgical scheduling dictionary, it basically all starts out with the request for a procedure term to be added. And this should ideally go through a check and balance system with, you know, clinical eyes on it to make sure that the procedure name makes sense clinically. Of course, the OpTime or the IT folks who manage that dictionary should be able to check that against the current procedures that they have in their dictionary already to make sure they're not making a duplicate procedure. And at the end of the day, once the procedure term is built, it should go through a process where it's vetted completely for appropriate CPT code coverage. So you may have to involve coders for that. Naming, so make sure there's clinical relevance to the naming. You get the surgeon's input and clinical input for that. And then as far as building, the actual building of the procedure, you would have whoever maintains that dictionary from an IT perspective. Anything to add, Alex?
Yeah, I think the only thing I would add, I think you nailed it, is that it can be a complicated process, and there's certainly something to be said for what are industry best practices, and that can also be a complicated question to answer. So looking at if there's a way for your organization that you can bring in some of that best practice knowledge, can really be something that helps you as you try to make this process better. So we got another question. So can we provide any examples of how hospitals have improved their data dictionary governance? So what we've seen a lot of hospitals do is a couple different methods that they've done that by. Just to lead off, it's a really difficult thing to do yourself. To really put the time and energy into it and have the right skill sets in place and really have the authority to say this is what best practices are. That can be a really difficult thing. So with a lot of sites, what we've seen is alignment to best practices, whether that's finding best practice procedure lists, or a full update of your dictionary and offloading the maintenance of it. That's really, I think, given healthcare organizations the ability to say, okay, we have this part figured out and we're able to handle it without a huge lift on our end. I don't know, you have anything to add to that, David?
Yeah, not much at all. I just basically just if from a general standpoint, you know, you have to start with a review. You have to start with a review, and as I spoke to at some of the slides, you know, you have to ask yourself critical questions on, you know, the status of your dictionary and the governance that's in place to manage it. And just like doing any process, find gaps in those things and fill them to make sure that at the end of the day, when you're done building your dictionary, you have the right sized procedure list to conduct business. You don't have any more or any less.
Just a reminder, if you have any other questions, please put them into the questions panel.
So we have another question. When reviewing your surgical procedure list, who do you recommend should be involved? Surgeons, surgical leads, etc. So I guess that's I mean that question is the same thing. I mean the procedure list I think should be reviewed initially to make sure that the procedures within it make sense clinically, that there's no ambiguity. Anybody reading that term knows what surgery is going to be performed after reading that term. So for that, of course, you would need clinical input. You would need, you know, in some cases, maybe the department chairs are going to revamp their entire list, and they're going to make a whole new list so that the names are more readable or more understandable. In other cases, the procedure list, it has to be accurately CPT coded. So obviously you would need involvement from your coding staff, your coding personnel. There's different procedures that are done, you know, obviously by specialty, and you can have subject matter experts from the different specialties have input into these things as well. But it's a multidiscipline approach, basically, with the core of it making sure that your procedure names make sense and there's no ambiguity.
All right, here's one. So can you explain in more detail how preference card management could be made easier with a cleaned up procedure list? Yeah, great question. We kind of touched on it, but didn't really go into detail. So for when you're really looking at your preference cards, it's a sort of a right sizing issue a lot of times, where you might have a really common scenario we've seen is that you'll have a surgery defined in your dictionary, and a surgeon from a service line not authorized to perform that surgery will need to perform that surgery. And there's a lot of oftentimes difficulty in making sure that the right surgeons are authorized for procedures. And so sometimes with a sense of urgency, you'll have a service line lead expedite a request to add a new procedure, and they'll put their own naming convention on it, you know, based on what they think is the right thing for that particular service specialty. And what ends up happening is then you have two procedures that are at their core, they have the same clinical meaning. The only thing that's going to be different about them within your dictionary is which specialties are authorized to perform it. And what we'll see a lot of times is that sites will copy the preference card from the other procedure over to simplify things. But now, as soon as you did that, you've put yourself in a little bit of a bind, because now you have two preference cards that are for the same procedure that are the same thing, with just potentially the addition, you know, of a few preferences for that particular surgeon. So when you're going and doing your preference card review, now you have twice the amount of preference cards to optimize for than you did previously, even though it's for the same procedure. So that happens very frequently, where you end up with that state of things. That's why we always say it's really important to clean up that dictionary, because when you clean up that dictionary, you can look at those two procedures that were created and say, you know what, these clinically these mean the same thing. And to go through those, when you look at both of those procedures, you can simplify it into one and really clean up the preference cards that are associated with that procedure. So that's an example, but you can see how having a single procedure that encapsulates a clinical need really helps you get to a shorter, right-sized for your organization procedure list.
Yeah, and then just to add on to that, that this usually happens. Dictionary health decline happens usually very insidiously. It happens without people realizing it, and we see examples of that all the time. We received a file from a client that had over 30 cases in there that had the word pacemaker in it. And it's obvious to us anyway that there's only about 5 things you do with a pacemaker in surgery. So obviously there was a lot of redundancy there, and they were managing preference cards on all 30 of those procedures. So, through review, they are able to, with a good review, you're able to right size those lists, bring it from the 33 or 35, whatever it was, down to the 5 it needs to be. And then you don't have to manage preference cards on 25 other procedures or 28 other procedures. So that's kind of a real world example, real life example of what Alex was speaking to just now. And we have another question. If we associate CPT codes to our procedures, how often do they need to be updated? Well, the simple answer to that is they need to be updated whenever they're incorrect, right? So that's an extra level of tracking that needs to be done to make sure that whoever on staff is in charge of these CPT codes, that they're keeping up with the, first of all, there's annual updates from CMS for the inpatient only procedures, and then from the AMA itself, as they're the ones that own the CPT codes. So there's annual updates there, but then just throughout the year, you may find that you need more targeted CPTs on a procedure, or you're doing a procedure and you're always missing a certain CPT code. So that level of update has to occur on a continuous basis, with the biggest updates, of course, at the end of the year after CMS and AMA make their changes.
All right, just a reminder, if you have any last minute questions, feel free to put them in the question box.
All right, yeah, and we have one. Do you have any case studies you can share of sites that improve their revenue outcomes with the healthy procedure list? Yes, we do. There's a large academic medical center on the West Coast. They saw a decrease in denials of almost 500K in a single year, just due to an improved dictionary and those EMR alerts that I mentioned earlier for inpatient-only procedures. There's been several other sites as well that were able to have a dramatic decrease in their denials due to that cleanup of their dictionary, making sure they have the right CPT code when scheduling, and having that inpatient-only call out on their procedures. Yeah, we've seen some really great ones. David, did you have anything to add to that?
Oh, I did not.
All right, so it looks like questions are winding down, and we're going to go ahead and close out for today. I hope you found the information in today's webinar useful. And if you want any more information about IMO, please contact your IMO client and executive, or also email sales@imo-online.com. Thanks for attending, and I hope you have a great rest of your day and stay healthy out there. Thank you.